Great, thank you. Welcome, everyone. Thanks for being with us. I'm Melanie Ridley. I'm the Chief Development Officer for IVI, and so pleased to be joined by a great panel. I'm going to just share a few opening kind of thoughts about this project before I introduce our panel. We are so incredibly grateful for the contributions of leaders across the health, care, patient advocacy, and health economics fields who have been with us throughout this project. We have an incredible steering committee, 13 stakeholders representing diverse perspectives. And as you could just see from Gwen and Gretchen and Jen's conversation, it's been very lively and robust, and we have really appreciated all of the feedback that they've shared with us as we move through this. We also have conducted key informant interviews with many of you who are on the Zoom with us today, and we really appreciate the feedback, and hosted a roundtable discussion with 14 stakeholders that really helped us to evolve our thinking and how we're building out a framework for researchers and others to reference around economic impacts to patients. So right now we have a draft framework that offers an organizing guide for researchers and decision makers, patients and caregivers to consider and explore what are those economic impacts, what's that full range that we're talking about when patients and caregivers interact with the healthcare system. And today we're hoping to discuss, lay the foundation for incorporating that rich complexity of the health journey into this. We have 3 of our partners from this project joining me today on this panel. And we're going to start, I'm going to ask Annie Kennedy with EveryLife Foundation for Rare Diseases to come on video with me, and she's going to share a little bit of information, and then we'll bring the rest of the panel on. So thank you, Annie.
Good morning. Good morning. Thank you, everybody, for and thank you, IVI, for this amazing 2 days, actually, and for inviting me here this morning. I have to say I have a little bit of regret that I had to submit slides ahead of yesterday and ahead of actually that past discussion panel. So I am going to navigate around and through them and probably not cover every slide so that we can get to the discussion panel. But I do want to honor IVI's request to share frame our discussion today with a little bit of a case study, and then I'll go through a little bit of the data, and then we'll dig in and move on for other co-panelists. So I was asked to share maybe help frame some of our discussion with a case study, and being a part of the rare disease community where there are more than 30 million Americans living with what are estimated to be 10,000 rare diseases, is very difficult to choose just one. But as I've been listening to the discussions, I do want to highlight the journey of a very close friend of mine that we may be able to draw from throughout our discussions, because it really, I think, speaks to some of the economic impacts that maybe we have a hard time eliciting when helping inform some of the decisions of various stakeholder groups. So I'm going to spend just a couple minutes talking about my friend Chad. So Chad was diagnosed, entered probably elementary school and middle school, still asymptomatic, was super athletic, but always in his life was thought of as being clumsy. It was sort of a joke among his family and his friends. Always known to drop things, fall. And when he was about 15 or 16, his clumsiness led to frequent imbalance when he would walk throughout the hallways in high school. He describes that he would need to hold on to the lockers. He was often thought of as looking like he was intoxicated or drunk. Well, certainly he was not. He would tell jokes sometimes that he would get pulled over by police officers when he was driving, and if he got out, they would think he was intoxicated. And looking back, he even reflects that sometimes he was thought to be slurring his words, although that was just known to be the way he spoke. He didn't really think of it as slurred language. He was, after a several-year diagnostic odyssey, diagnosed with a diagnosis known as Friedreich's ataxia, which is a rare form of ataxia. and was given a life expectancy of 2 to 3 decades from diagnosis. And he was diagnosed at the age of 15. He had no family history of this, and it was stunning to his family. He was the son of a firefighter, and his mother worked in the food industry. He lived in Baltimore and had aspirations of being an attorney, and was really hell-bent on doing that. He went to college, formed really close friends in his fraternity in the Baltimore area, and coming out of college, was still somewhat ambulatory. You can stay on this slide, but was using a power wheelchair to ambulate campus full time, but could still do his own transfers at that time. In the physical disability community, the ability to self-transfer from your wheelchair into your car, or into your bed, or into your shower is a really critical inflection point, because that speaks to your level of independence and your level of caregiver need. So he really clung to that ability for a very long time. It was right after college that he lost the ability to transfer himself, and his caregiver need increased. He started law school, but his caregiver needs and his declining upper body strength, and his inclination for fatigue, so his really impacted him. Friedrich's also has a cardiac implication. So the more and more tired he became, the more detrimental that was for his cardiac health. So his healthcare providers convinced him that maybe law school was not the best route for him. He became a formidable disability advocate. He worked on the Maryland Disability Coalition. He worked for the League of Persons with Disabilities. He did eventually own his own condo. He had an in-home roommate who did help provide care to him for a while. But all this time, he never qualified for benefits for somebody to provide care to him. He was not eligible for those benefits. Friedrich's ataxia at that time did not have its own ICD code. It fell under a broader list of codes, and he was not able to get benefits. His mother provided care to him for some time, and at the age of 18, his mother was killed very suddenly in a car accident. His father then tagged in to be a care provider, and when Chad was in his early 20s, his father also died. So Chad was a young adult with a very significant physical disability, a limited life expectancy, and now had no parents to help care for him. It was not until Friedrichs advanced to the point where he lost his vision and his hearing that the loss of vision and hearing qualified him for eligibility for benefits, and he could get more than 4 hours a day of caregiver relief. His durable medical equipment at that point became reimbursed. He could have a caregiver in his home more than 8 hours a day at that point, not 24 hours a day, but more than 8 hours a day. And the days when caregivers wouldn't show up, he would just have to lay in bed. He had to leave the workplace because of the lack of caregiver support, and his healthcare then declined. I share this story to share that we spent a lot of time yesterday talking about the math. We spent a lot of time talking about how to do this health economic work. And I submit to you that patient organizations have to do this work, because we have to make sure that these experiences are counted. And we have to do a better job of informing the decisions of those who are working within our ecosystems, those who are developing therapies, those who are making decisions about reimbursement and eligibility, not just the HTAs, but those who are determining what about our lives are of value. Okay, so next slide. And next slide. So here are just some of the perspectives of the economic data and the approaches to economics that our community have taken. This is a quote from another leader within our community, Marisa Penrod. Her son lives with Duchenne muscular dystrophy. As we were working on our national economic burden of rare disease study, she reflected that the financial challenges are overwhelming and unrelenting. The search for a diagnosis or treatment requires navigating a complex medical system and battling with insurance companies, all while trying to hold down a job. Next slide. Another friend of mine, Allison Bones, who lost her son to a rare disease, reflected as we were also doing this work, balancing a career with medical care is tough. You might not be able to complete everything your manager asks. You might not advance at all in your position quickly, if at all. Next slide. Another friend of mine, Steve Smith, who is a father of a son with a rare disease and also works in the biomedical space, reflected, if a family cannot afford to repair an electric wheelchair, buy a hearing aid, fix teeth, or travel to specialists, then the person with a rare disease receives inadequate care. These costs accumulate and limit educational and career opportunities, making it harder to contribute to society. Okay, next slide. So we know that many of our ecosystems are now including patient experience data within their decision frameworks. This is from 21st Century Cures Act and speaks to how patient experience data is being integrated into decisions within FDA. And you'll note that as we look at what the relevant categories of patient experience are, one of the first bullets that are pulled related to FDA is that the burdens of disease and its impacts on patients' daily lives are considered. Next slide. And this is an image of the patient experience data checklist that FDA now uses within its regulatory review. And you can see there all the guidances that are being developed, and underscores the importance of us really translating the lived patient experience of our community members into data that can be utilized for this decision-making. Next slide. In another partnering ecosystem, when we think about our health economics, our access partners, I was a part of the Duchenne community when we had our first approvals in Duchenne, and when we would work with payers. So we had done a really great job of working with regulators to make sure that some of these considerations were going into informing our clinical trial designs. But then we got into a very complex access environment. And we then started working with payers, both public and private payers, and then went through the ICER assessments. And what we found was that the data that was needed to inform decisions within those ecosystems had not been collected the way that those partners needed them. And that was a big wake-up moment for us. That was, hindsight was 2020. We wished we'd been collecting that data differently and decades before. And so if we go to the next slide, we embarked at EveryLife to really embark on a formalized data collection of health economic data that would reflect how we could maybe begin to think about collecting health economic data that would reflect not just direct costs, but the non-medical and indirect costs that were being experienced by the rare disease community, and that would hopefully serve as a template for other communities to do the same. And to do this, we partnered with many of those, the partners in those ecosystems to understand what types of data they would need, how they might use it. We had been a part of many roundtable meetings and ICER assessments and had listened to the reflections of the members of the roundtable as they would listen to patient community testimony, be moved by that testimony, but then reflect on the fact that they wished they'd had more data to bring into their decision making. So if we go to the next slide, I'll just take you through a couple highlights from that. For the sake of time, we won't spend a lot of time on it, and you all have access to the report, but next slide. So what we did is, as I said, we were trying to move from back of the envelope estimates to really quantify what the lived experience of rare disease was. And again, not just look at direct costs, because as I mentioned, especially as I talked about that experience with my friend Chad, and in those quotes that I had from Steve and Marisa and Allison, so many of the costs being experienced by families are not costs being reflected in our EOBs. Next slide. So we looked at direct medical costs, indirect costs, or productivity losses, and the non-medical uncovered healthcare costs. In order to look at these latter two categories, we conducted a survey of the patient community. If you go to the next slide, it describes a little bit of who was included in that survey. We worked with our broad patient community. More than 200 patient advocacy organizations helped us develop the survey to determine what would be included in that survey. And I'm happy to share the survey itself with anybody who's interested. We are happy for people to build upon that survey. We had more than 1,400 people complete the survey during the summer of 2020. And what we were examining were healthcare costs for 2019. So 1 year of data. So next slide. And what we found was that you can stay on the slide, that's fine. For 2019, the costs were close to $1 trillion, so $966 billion. If you go to the next slide, what we were looking at were 379 rare diseases. So the way we found that was that we took the survey respondents, those 1,400 survey respondents, we looked at that data to make sure, to verify that those individuals were indeed living with a rare disease, and we correlated their diagnoses to the corresponding ICD code. And of those 1,400 survey respondents who had rare diseases, they were living with 379 rare diseases. So that was the direct cost data that we pulled over. You'll see that of those costs, about 40% of the costs are represented in the direct costs, the direct medical costs. The remainder were the productivity losses and the non-medical healthcare costs. So if we go to the next slide, I just want to flag, when we look at the direct medical costs, while the cost drivers were inpatient, outpatient care, the durable medical equipment and caregiver costs were at the bottom here as far as cost drivers were concerned. One of the things that struck us when we were looking at this data was it's not necessarily because those weren't costs that are needed and being paid for by the patient community, but they're not being reimbursed by the healthcare system. They're being paid for out of pocket, so they wouldn't necessarily be represented in the direct medical costs. If we go to the next slide, this is what the productivity losses look like. So absenteeism, presenteeism, forced retirement. It was important to our community. We not talk about it as early retirement. This isn't because you saved well and bought a house on the beach. This is because you were forced out of the workplace because you or yourself are caring for a loved one or have a rare disease. If we go to the next slide, kind of wrapping up quickly. These were the costs that are prescribed, are necessary in order to live with a rare disease or care for your family member, but are not reimbursed elsewhere, that are coming directly and being shouldered directly by families. This was a substantial part of what we uncovered and that our community felt were really validating. I do want to say that for a lot of our families, these are things that families just have to go without and really compromise people's abilities to live. One of our family members really reflected on the fact that the ability to live with a rare disease truly does depend on your ability to financially pay for that rare disease. And that is what's represented here in this slide. Next. I'm just going to end on this. We included a data point in our study looking at what the diagnostic odyssey in rare disease was. We worked with the Undiagnosed Diseases Network to include that in our survey. What we found was that the mean time to diagnosis of our survey respondents was 6.3 years and included 17 providers. This is a huge, I'm going to just put an asterisk on this when we talk about equity in rare disease, because what I worry about here is who's not represented, who didn't successfully navigate to a confirmed diagnosis, who can't get to healthcare providers. If you go to the next slide, who can't travel out of state. That 6.3 years and 17 providers is probably a best case scenario. And there are a lot of people getting left behind and not represented in this data because they can't navigate this system and get reimbursed for their care or their caregiving needs in order to get that diagnosis. And if we go to the next slide, we are right now conducting a follow-on study looking at the economic impact of timely diagnosis in rare disease versus delayed diagnosis in rare disease. and we'll be releasing the findings of that study in early May. And so I think we're at the last slide. And so I think maybe I'll just end with, I really appreciated yesterday the presentations and the conversation. And I do understand that this is really hard work. And I think we were yesterday talking a lot about that it was about math. I would submit that it's not about math, and that it's about being counted, and that rare disease communities are moving legislation and moving financial resources and federal funds and regulatory frameworks and asset access frameworks. And we are absolutely capable of being meaningful partners in health economic work. And it's not a should we, it's a we must. So thank you for including us here today.
Annie, thank you so much. I mean, just reflecting on the $111 billion burden placed on the families and caregivers in your report, you know, thinking back to, I think something Gretchen mentioned about, we have to think about this from a mitigation of risk to patients and families. I mean, consider that as just an enormous risk that we are placing on the shoulders of patients. So thank you for sharing that story. I'm going to ask our panelists to join me on video. So Annie, you can stay on video, and welcome Mary and Juan Marcos as well. Before we jump into some questions, I want to display the framework that we're working on, just to kind of give us that context, and I think frame you know, what you just shared in terms of the story, Annie, that you're telling. So Judy, I'm going to ask, can you display that one slide? Great, thank you so much. I'm not going to spend much time on it, but just wanted to share with you all. I believe Erica put in the chat a pre-read document that provides this draft framework. This is what we've been working on with our steering committee, with our key informant interviews, with our roundtable, is iterative process of defining some domains, some of these aspects of economic impacts. And so we really try to use that person-centered language here in defining domains where we think it might capture that full range of economic impacts. And so you can see the 6 domains of, you know, both that direct medical cost as well as non-clinical healthcare costs, some of those things that are not reimbursed by the system, so are not being captured, as Annie mentioned, as well as social impacts, ability to work, that impact on career trajectory and opportunities, as well as educational opportunities, and then the caregiving and family impacts. And so this is something that's, you know, in process. We're gathering feedback and hoping to share this report out with you later in the spring. Just a centering place, a grounding framework to begin talking through some of these economic impacts. So we can lower the slide. And with that, I'll say thank you to Juan Marcos with Duke University and Mary Reed with Kaiser Permanente and Annie for joining us in this panel discussion. Just wanted to ask, you know, as you know, Annie shared in that report, both, maybe I'll start with Mary. What are some best practices that you've seen in capturing those economic impacts on patients and caregivers that Annie referenced? Anything you're seeing that kind of you can point to as where it's happening in a positive way? We're seeing some progress.
Hi, yeah, thank you. Glad to be here. I guess, first of all, I want to say I'm really impressed with the work that Annie's group is doing. I just kind of blown away by the breadth of what they're doing. I would love to see it sort of overlaid with the framework. I think that there's a lot of work being done. I would say, you know, many researchers, including myself, try to do some of this work, and we do it sort of piecemeal in little corners here and there. We do as sort of what we can get funded, what we can reasonably capture, what fits our project. And I think we know on some level that, you know, we're not really capturing the whole picture, and that's a frustrating thing for us and for patients. And I think what this enables here the framework enables is a chance to do our best to see the whole picture. I think it really fills a gap where, like I said, you know, my own work is sometimes sort of ad hoc or piecemeal, or makes do with proxy measures of many of these factors. And having it laid out in the framework, you show the main depiction of the framework, but each one of these domains has so many sub-bullets. And I think it'll really enable us to do a deeper dive and do a better job of capturing as much as we can of the patient's indirect cost experience.
Great, thank you. Juan Marcos, anything you can point to where you're seeing some progress, best practices coming forward?
Well, certainly in the area of research that I'm a part of, which is preference research, there has been a lot of work looking at what some would call unconventional sources of value, right? Things that go beyond clinical outcomes, looking at the patient, not as a patient, but as a person, as the framework highlights. And I think it's been, in my view, sort of a twofold effort. On the one hand, there's a lot of work that, as Mary said, looks at kind of in a piecemeal way, make a dent and try to identify different values as we identify them, and more importantly, putting them in the context that is useful to decision makers. Namely, it's not enough to say that something exists, that a particular value exists. I think, just as Annie did with the work that has been shared, it's important to put it in the units that can impact decision making. So in terms of dollars and cents, because ultimately that is the way it's going to be contrasted against the different options that are available. The other line of research that I think is developing as well, and can potentially have an impact in these discussions, is the space where we are looking to bring these assessments to treatment decision making, to the clinical encounter, because I think that the battlefield is partly in terms of having these discussions at a system level, but it's also partly in terms of making these acknowledgments when individual decisions are made, right? When patients are having to make choices between specific treatments that potentially have all these consequences and affect more broadly their lives. And so I think that requires a new set of tools that are being developed that go beyond, blood pressure or A1C, that involves how do we make these discussions between patients and physicians more effective, so that physicians, who are understandably also incredibly busy, have an opportunity to take into account the person, not just the patient.
Mm-hmm. Absolutely. I think, Annie referenced some challenges in capturing this type of information, and certainly hearing from both of you that you're having to use proxy measures now because we don't have the right tools. Annie mentioned one piece, which was a lot of this isn't captured through the healthcare system directly because it's not reimbursed, say, by an insurance plan. What other challenges are there that we're going to face as we think about, taking a framework that really builds out these economic impacts in the domains and where patients and caregivers are experiencing this financial burden? What challenges are we going to face in trying to bring in some of these measures into research? And I don't know if I'll leave that to, anyone to start.
Yeah, I can start a little. I think that being involved in that roundtable process with IVI and with the stakeholders that joined the roundtable was really, it's really eye-opening. It was such a rich experience where I think a lot of the conversations with patients really resonated with the whole group. It was primarily a patient it was a mixed stakeholder group, but it was probably, a good half or more were patients. And then there were, foundation staff and researchers like me and others in the room. And I think what it emphasized for me, well, first of all, is a lot of admiration for the work that went into developing the framework. But what it emphasized for me is the need to translate this into measures, like you were just saying, Melanie. Basically, the next step, now that we have a framework to lay this out more thoroughly than I've seen before, what we need are measures, ways to measure these things. That's the way, my hat as a researcher thinks about this. And I think there's still a lot of work to be done, that the groundwork has been laid, but measures are needed. And then I remember saying during the roundtable, and also sort of my instinct as I think about these things now, I mean, those of us who are grant-funded researchers, which is, I think, a great portion of researchers in our country or elsewhere, we can really only study what we can get funded. And, no matter how inspired we are about this stuff, and I am, I think about, well, who could I get to fund this kind of work? And PCORI comes to mind. I know they've come up a lot and they're funding part of this work. And they have, again, sort of offered such an admirable model of patient engagement. It's not perfect, but it's like leaps and bounds ahead of many other funders that I've interacted with. And so I think that it sort of just emphasizes to me the degree to which we really need more funders to give us an opportunity to really engage with the depth that is needed in this work.
Great, thank you.
Yeah, I absolutely agree with that. And I would just add that I think there's a bit of a mindset problem that we have to deal with. And I think it's been alluded to already many times in this discussion this morning. There is this idea that when we are treating someone, we're treating, again, the patient, right? And so the optimization, if you will, of care is based on optimizing the outcomes that relate to the patient. And so I think that even though we have plenty of evidence that suggests that that perhaps is not the best way to do things, there is a general reluctance to think about it that way. And I think that one of the prime examples, in my view, is the issue of treatment adherence. Right? I mean, 50% of patients who take hypertension medications are non-adherent, up to or about 50%. About the same percent of patients who take adjuvant therapy for breast cancer are non-adherent. And instead of asking what is wrong with what we're asking patients to do, we keep asking instead of asking what is wrong, with what we're asking patients to do, we keep asking what is wrong with the patient, right? And even the work that's been done about removing barriers to treatment is still based on the premise that the ideal scenario is for patients to be 100% adherent to treatment. And so I think that is a very narrow definition of optimizing outcomes. And so moving or evolving that mindset so that this optimization is seen in a more holistic way, as has been shared before, in the form of a person, not just a patient. I think it's going to be a challenge, and we're not there. I think this framework helps us move into that direction. The decision to put a person in the middle of the framework as opposed to a patient, to me, speak volumes in terms of where we want to be.
Well, and I think that concept, Andy, just so one moment, I'll be right with you. But I think that concept of the mindset shift was such a strong theme in yesterday's conversations in terms of equity and centering, our research and our work, around this on equity. And so I really appreciate that and sort of that reframing. So Annie, yes, please.
So just a couple things. So first of all, I want to make sure, I think most of the people here know, but I just want to make sure that I am not a health economist, although I'm participating in my helping to lead my third health economics study. And so I say that because I approach all of these questions as maybe the agitator of our partners in any of the endeavors that we come into, because I approach all of these questions as a patient advocate and a policy person. And so, for example, when Juan Marcos was just asking the question around adherence, whenever I hear the term adherence, I think of it in terms of, well, it's not to me about adherence, but where are the barriers to filling that prescription? Where are the barriers for the patient to taking that medication? Where are the barriers to reimbursement? Where are the barriers to what is that medication doing or not doing for them? So, framing it in terms of adherence presumes that taking that medication leads to the intended outcome. But oftentimes as patients, we're not asked whether or not that outcome is actually being received, for benefiting from that. Can we pay for that medication? Can we take that medication with the other diagnoses we're experiencing? What else is going on? And so I think when we're approaching in terms of this health and economic data, what I really like about this framework is it's not just about putting the patient in the center, it's about putting the patient in the context of our lives. Mm-hmm. With whatever our family circumstances. This framework is one of the first times I've seen impact on siblings get pulled out, which is incredibly important in the dynamic of a family. So I just wanted to flag that. And, going back to your first question, I do spend a lot of time, again, because I like to catalyze and agitate a little bit. We've had some wonderful health economic partners who are much smarter than me on these things, but I like to ask a lot of tough questions. Can we do this? Can we look for this in the data? Is our data helping us find this? And I spent a lot of time thinking about who's invisible. What are we not answering in this data and these questions? I already spoke about the ICD codes. Like, I think of our data as hashtags. So what are we not collecting? Who are we not collecting data on? What subpopulations are not being represented? What demographics are we not in a meaningful way asking questions about, that we cannot be answering questions about comorbidities? When we had the COVID data trackers stood up at NIH and CDC, I went to CDC and asked if we could do some data tracking to look at the risk for COVID in our rare disease community. And because of our lack of ICD codes, we couldn't look at the increased risk in the rare disease community and the COVID data trackers. So where are we harming ourselves by not collecting this data? I already talked about one of the things we worried about when we looked at the diagnostic odyssey in our data in our first study. Who wasn't represented? Who can't travel out of state for a diagnosis? So who doesn't get a diagnosis in rare because you don't get reimbursed for going out of state, or can't pay for care to go out of state? So who's not getting reflected even in the good data that we are collecting? So those are the things that I stay up at night worrying about, and I think we need to do a better job of thinking about. I did see somebody put in the thread around educational impacts, and are we collecting data within the educational system as to what's happening there, where there are opportunities to streamline resources. And then the other thing I just want to flag is comorbidities. We all are serving multiple communities here, and there's crossover and impacts. And I understand that that makes data dirty and harder to work with, but we need to be looking at that. And what are the potential impacts of living with multiple diseases, being on prescriptions for multiple things? What is the interplay there? I think the tendency sometimes is to not include people with multiple diagnoses, certainly not in clinical trials. That makes it very complicated to look at the data. But in rare disease, many people tend to have multiple rare diseases. So what happens then when we're not counting you, when you're not a part of these experiences? So anyway, just some things to tease out that I think as we look at improvements and how we do better and enhancing the work we do, how we wrestle with some of these things.
I think that's so powerful. And certainly as we've been talking with stakeholders and reviewing the framework and trying to bring some of this forward, that intersectionality of all the different components of, a person's life, their family, their community, is so important to capture and so challenging to capture in a framework and then think about in research. But I think the way you approached it with those questions of, thinking about what questions to ask at the beginning and try and explore where are there opportunities to capture some of this. And I just, I was reflecting on the comment about shared decision making and the role of clinicians in asking some of these questions. And I mean, our healthcare system is so complex. Most of the time, clinicians don't even know how much the cost is for the patient to come in for that specific visit, let alone some of these other impacts in terms of non-reimbursed, burdens and economic, costs to the patient. So, certainly a lot of challenges. Juan, Marcos,
Yeah, I do want to add something because I think it's important, from my perspective at least. It is important to understand that this is not necessarily an issue with economics. As a token economist in the discussion, I have to come out in defense of economics, because this is, in my view, an issue with the intersection of health and economics. We do things in health economics that are not done anywhere else in economics, for a variety of reasons, good or bad. To go back to that point about adherence, if McDonald's tomorrow releases a sandwich that only has a 50% uptake, versus what they expected, they're not going to ask what is wrong with the customer, right? They're going to ask what is wrong with our sandwich, right? And I think there are tools and methods that are used in economics that could be used in this space. Now, it is true that health poses some unique challenges. There are some characteristics associated with health that make the use of these tools complicated. The first one of which is the reluctance to talk about money, which seems, in this context, seems a little ironic, right? We treat health. So maybe not so much in the US, although I would argue that it is similar. But if we look at Europe, which has a lot of virtues in its system, but there is the idea that we're going to carve out, for political reasons, a particular pool of resources, right? And then we're going to optimize within those resources. And so that carving out basically excludes, or sort of systematically puts these fences between what can be contrasted against health outcomes, right? Because we're just looking at what's in that pot. And I think part of what could help, in my view, move this discussion forward is accept that, as cold as it might sound, patients, first of all, we're all patients. At the very least, we're all aging, right? So secondly, we're all consumers, and we face trade-offs every day. When we have to go get our blood work done, we have to carve out time from work. We have to decide who's going to take care of our children. And so this idea that patients are not making the right decision because they're not going to get their blood work done is demeaning, right? In some ways, the way that patients act, and it's assuming that patients don't have the ability to be the judge of their own well-being, that what's best for themselves. And so, I think that there are, beyond the preference work and the tools and the databases, I think there's definitely system level issues. And I totally agree with Annie that we can't improve what we can't measure, right? And so if we're not measuring the right things, we're not going to be able to make improvements. But my own perspective is that is a symptom of this mindset. That is a symptom of this idea that a patient is a patient, and we're gonna look at this person as separate from the rest of their reality. And I think that needs to change.
Yeah. Mary, I wonder if I can ask you just to sort of reflect on, your research within a health system and thinking about, if we are able to overcome some of these challenges and begin to measure some of these economic impacts, what do you see as what would improve, from your perspective as a researcher? How is that going to help you better understand the changes that your health system is interested in making in healthcare delivery, or understanding the patient experience in a different way? But what do you see as what will be different if we are able to overcome some of these challenges?
Yeah, it's a great question. I'll say I'm a researcher embedded within a healthcare organization, but I don't have any direct levers to improve care within a large, complicated organization. I'm reflecting broadly on how research or data captured within a framework like this can inform care. I think you can't, the healthcare system can't adapt to reduce the patient barriers it can without knowing what the patient barriers are. So I think that at the very premise that we have to start with understanding, having a patient in the room, and many patients in the room ideally, and understanding what their barriers are, what their indirect costs are, what their economic impacts are, can begin a conversation about, well, what are the levers within, this sort of shared interaction where we can help to reduce patient barriers. So I personally do a lot of work in understanding the way that digital tools, including a lot of telehealth these days, telehealth research these days, can affect the patient healthcare experience. And it's not perfect, but we do a lot of thinking about to what degree do patients, can a digital interaction help patients avoid having to take time off from work, avoid having to necessarily get childcare in order to go all the way to a doctor's office, can help a caregiver of a dementia patient maybe avoid some of the really, really burdensome hassles of bringing a patient all the way to clinic. It's not perfect. Digital tools can't replace, all healthcare, and no one is in the game of saying that. Digital tools have a whole bunch of technology barriers that come along with them also that have to be overcome. But I think that having an honest conversation and a thorough conversation with the data in front of us about what the barriers are that patients face for care can start to redesign the care seeking and care experience process to remove what barriers are potentially addressable.
Annie, thoughts from you in terms of, from your perspective of being involved in the report that you're working on, capturing or attempting to capture some of these economic burdens placed on families and caregivers. Thoughts from you on, if we can, work with a framework like this, better capture some of this in a more standardized way. How does that, improve healthcare for the patients and families that your organization represents?
Yeah, so I tend to skew optimistic always. So I would say, absolutely, we must. I would also say that since the report first came out, it has certainly opened up, really important dialogues and conversations with so many different stakeholders and ecosystems that we hadn't previously been able to communicate with. I really think of it in terms of maybe having a common language to begin to speak with one another. I think there are a lot of really well-intentioned partners in different stakeholder groups that even when you do bring a room full of articulate and wonderful patients into a room who tell their stories, there are stakeholders who truly just don't know what to do with that, right? It's not at a level of data that then can be used to inform decision-making. So I think that these efforts within the framework that IVI is helping lead create, or the burden study that we did, and many other groups are embarking on this work as well, are really the beginning of creating this maybe common language. I think the challenge is maybe now taking it to the next level to understand, and this is where I think IVI serves a really important role, is understanding how all of this is going to be used and having those various different stakeholder groups create frameworks for us to understand, if we do this work, if we invest in this, how and when will this be used? And we've seen this in, partner ecosystems, right? When FDA created, I showed that patient experience data checklist that sort of sent a signal to the academics and the social scientists and the industry groups and the patient groups that were creating those patient preference studies and those PROs to sit in the COAs to say, this is where we will use it, and to sort of start to develop guidances around standards and representativeness, et cetera. I think very similarly in ecosystems such as within payer groups and HTAs, we need very similar matrices and frameworks to say, there will be a formalized process by which we will utilize this data. And this is how, in order to send signals that that investment will be well spent, and there will be formalized time points in which we will integrate this into our decision-making, and it will be centralized within our decision-making. That to me is an important next step. And to the point that I think we also need to move towards a time point where we say that these decisions, these value assessments are not intended just to inform a payer's decision-making, but also to inform the decision-making of patients and providers who at the end of the day are the ones who have to make decisions about which products are right for which patients at which point in the disease trajectory. So really the evolution maybe of this work, but establishing those frameworks now will help inform how we do this work upstream.
Excellent. And I think you just touched on what is going to be my final word. We're wrapping up here, and just want to ask you, each of you, as we close out, what would be one action you would recommend that those listening to today's webinar take when it comes to, reviewing this framework and thinking about this framework? Annie, what would be one action you recommend to our viewers?
I mean, maybe it's not an action, just a challenge is partnership. I mean, we have just really benefited from partnering with those, in other spaces and ecosystems and learning from one another. And I would just challenge everybody who's here today. And I scrolled through the participants and I'm thrilled to see some friends and colleagues and people we've worked with and learned from over the years. But maybe everyone here needs to leave today and establish one new relationship or partnership with somebody in a neighboring ecosystem, because that's how we build on the work that we're doing. So that would be maybe my takeaway or challenge today is let's keep building on what we're doing together.
Great, thank you. Mary, I'll go to you next. One action.
I have so many. I want to piggyback on Annie's. I mean, I think being involved in this process, and I've had PCORI funding and have worked with patients in a variety of ways, throughout my career. But one just overwhelming learning for me in being a part of this process that I hope that we can all take forward is just the incredible value of involving patients, to make sure that there's a patient, at least one patient, probably more patients at the table. It leads to better projects, it leads to better data, it leads to better policy, it leads to better outcomes. I'm really, that's my take home, and happy to share it.
Excellent, thank you. And Juan Marcos, close us out.
Well, I would challenge everyone to think about their own lives as they're reviewing these framework, and think about the things that you value that might seem unconventional, and think about how it is acceptable in almost every other setting. And how it might be incorporated or it might be relevant to decisions around patient care. I think that we need to, part of what we need to do is start thinking about health in the same way we think about the other things that happen in our lives. We don't question when a man in his mid-40s buys something fancy because they're going through their midlife crisis. We don't question the resources spent on such a whim. Yet we question when a patient talks about the value of hope. or we question when a patient talks about the value of reducing uncertainty around their outcomes. So I think that thinking about eliminating that fence and how we can inform what we do in patient care based on our own experience in other areas of our lives.
Thank you. I think yesterday we were talking about being evangelists around health equity, and I think, you know, you sharing the intersection of health and economics, maybe you're going to be our evangelist and move these economic impacts forward. I want to thank Annie, Juan Marcos, Mary, thank you so much for joining us and being on this panel. And I'm going to turn it over to Jennifer to close us out for the webinar portion. Thank you.
Thanks, Melanie. Rousing conversation, as always. One of the things we're most proud of at IVI is that we tackle complex issues, and we bring some pretty amazing thought leaders from all different sectors of this conversation to have these, I think, Mary, you said it, to have these honest conversations. What a powerful morning. I know that for many of you who will not be staying on for the consensus portion of this, this has whet your appetite, and you probably have many more questions about what comes next and how can we be involved. To share with you, as part of this PCORI funded project, the framework that Melanie shared with you, we're going to be rounding out our report and thinking about the principles that should be applied to using it, thinking about ways we can articulate how this framework might be used. As you've just heard the prior panel, we'll be publishing that probably later this spring for public awareness, so everybody will have access to that. And we certainly see this as a beginning of a conversation, not an end. And we hope to explore ways that IVI itself can put these domains into our practice. And so that's one of the things that we wanted to leave with you. I love that Annie was able to share the work that EveryLife has been doing, because it shows you that, as usual, patient communities are leading. They're thought leaders in this conversation. And we know, as you know, as patient communities, we know the questions that need to be asked and answered. And it is just wonderful to see an operationalization of the framework that we've been talking about for the last several months in the form of that burden study. So we can't wait to learn more. And lastly, I will say what Melanie said, do carry forward your interest and learning from today to your colleagues, to others in your network. Bring them forward. We welcome all of you to get engaged in what IVI is doing, not only in this project, but a variety of things. And if you don't know us and you want to know more, please reach out to any of us, myself or Melanie or Erica. We are happy to get you plugged in to the types of work we're doing, because we take very seriously our role in tackling some of the complex issues and really unpacking meaningful ways to make change happen. That's kind of part of our DNA. So thank you to all of you for making time for this second part of our Method Summit. We really appreciate your time and interest in what we're doing. And for those of you that are staying with us for the afternoon session, just hold tight, and we'll be converting you over to a panel format and go from there. So thank you very much, and have a great day, all of you.